يعطيكم العافية جميعا. اليوم راح نحكي عن Adam's clasp as a part of removable orthodontic appliances. So, as you know, in orthodontic treatment, simply we make the teeth straight. So we got a tooth patient with crowding like this, and we move him to something like this. So, uh, plenty of things that we can do with orthodontic appliances. One of them is to relieve crowding and correct the malocclusion. So, how we do this? We have different types of orthodontic appliances. The first one is removable orthodontic appliances, which is simply from the name, as in the name implies, the patient can wear these appliances and he can take them off. As we can see in this photograph, this is a photograph of removable appliances. The aim of this appliance is to push the sixes distally, to distalize upper sixes. As you can see that we have two arms around the upper sixes, moving them distally. So this is one type of orthodontic appliances, and this is the type of the appliance that we're going to focus on this semester. The second type of the orthodontic appliances is called functional appliances, and as the name implies, it's related to the function. As you can see in this photograph here, you can see two blocks, the one block in the upper and one block in the lower. Forget about the orthodontic braces that we can see in the upper incisors. Just focus on the blocks. Now these blocks work by function. How is that? When the patient is closing his teeth, he is forced to move the lower jaw forward. So when he moves the lower jaw forward, this is going to stretch the muscle of mastication. Now this can, in theory, will result in stimulation of the growth of the mandible. You're going to take a separate lecture talking about functional appliance, and in the next semester in the lab we're going to discuss functional appliance in details as well. So for now, what you need to know that these functional appliances work by stimulation of the function to stimulate the growth. So they are using the function to stimulate the growth. The last type and the most common type, and I'm sure that most of you had or at least knew someone that he had all fixed orthodontic appliances like this. So what we're going to do today is just to discuss the removable orthodontic appliances. As you can see for this patient, she has a reversed overjet. She has a class 3 incisors. She was treated with removable appliance. This removable appliance worked to push the upper incisors forward to correct the crossbite. So she had a crossbite like this, and the aim of using the removable appliances was to push the upper incisors forward to correct this crossbite. And as you can see from this photograph, this is good that the crossbite is corrected, but it's not the ideal result because we still have spacing and the canine is not aligned. And this is kind of nice case because it tells us the advantages and the disadvantages of removable appliance. So what is the advantage? Now, first of all, using removable appliance can give us the chance to use in the posterior, as you can see, is something covering the posterior teeth. This is called the posterior bite plane. So it kind of separate the teeth. By that, we can push the upper incisors forward. Because other than that, the lower teeth will prevent us from pushing the upper incisors forward. So we have to disclude them. And removable appliances are really good in that. But removable appliances are only capable of doing what we're calling tipping movement. They are able to tip the teeth, not to move them bodily. When we say bodily, we mean that the same object will move in the same direction with the same speed. All the parts of the object will move in the same direction with the same speed. This is we call it bodily. But tipping movement, now when we tip the tooth, it's gonna move one side of the when we apply the force, one side of the tooth will move in one direction, and the opposite side of the tooth will move in the other direction. So for example, if I apply the force in the crown will go in one direction and the root will go in the opposite direction. This is what we call it tipping movement. And that's what happened here. So if you look, now we tip the teeth forward. Now we can't use removable appliance to extrude the canine. We can use removable appliance to close the diastema because they're gonna tip وبيضل عندنا like a triangular space between the upper incisors. So now we have to move to the fixed appliance, which gives us a chance to finish the case nicely. So now we're going to talk about the components of the removable appliances. Now, how do we use removable appliance? We need to know the component. The components of the removable appliance are summarized by something we call it ARAB. A stands for active component, R stands for retentive component, A stands for anchorage, and then B base plate. So looking at this photograph here, we know that this appliance is used to push the upper incisors forward. So now in this appliance, we have the active component, which is basically the part of the appliance that is responsible of pushing or proclining the upper incisors. So this is what we call it the active component. And in this appliance, we can see it that this is the wire that is called double cantilever, and you're going to cover this one in later during this semester, is responsible to push the upper incisors forward, and we call this active component. Then we have R stands for retentive component, which is basically, as in the prosthodontics, retention is the resistance for the vertical displacement of the appliance. So basically, I just don't want this appliance to fall off the patient's mouth when he's talking, when he's eating. So we need something to retain this appliance. And as you can see, we have four retentive components, or these are Adams class, which is the most common retentive component. And these are the topic of our session for today. So we have one on each first premolar and one on each first molar as well. So we have four retentive components in this appliance, and these are Adams class. So the job and why we use Adams class, or just to retain the removable appliance in its place. So back to Arab, we said active, retentive, then anchorage again. It's A, anchorage. Um, we're gonna cover anchorage in details later on. So there's no need to talk about it right now, but later on we're gonna cover it in detail. Now, and the other B stands for, and the B, sorry, stands for base plate, which is basically this red in the color. It's the acrylic that joining the different components together. So now I have Adam, double cantilever, and another Adams on the other side. I want to join these parts together. I'm using acrylic base plate to join all of them. Acrylic base plate is made of cold cure polymethyl methacrylate. We don't use heat cure because heat cure is more expensive and it needs more work and it has superior mechanical properties that we don't need because um, orthodontic appliances usually used for a couple of months before we stop using them. While complete denture, for example, where we use heat cure acrylic, we need to use dentures for quite longer time. So now let's talk about the Adams clasp. What are the different components of the Adams clasp? You can see that we have the arrowhead, which is this one, and then we have the bridge, which is this one as well, and we can have the flyover, which is the part above the embrasure, and then we have the retentive arm. So what are the features of the arrowhead? So the arrowhead, as you can see, they should first engage the mesobuccal and the distobuccal undercut of the crown. And that's why we need them. Because if they don't engage the undercut, then they're not gonna function. If you look to this photograph, this is the area where we call about the mesobuccal and the distobuccal undercut. I'm just gonna log out just to use the pointer. So if you can see here, this is here the mesial, this is here the distal, this is here buccally, and this is here palatal. This is the number 6. So here is the buccal undercut, and here is the mesial undercut. So we are aiming for this area, which is the mesobuccal and the distobuccal undercut of the first molar to be engaged with the retentive arm, which is the arrowhead, sorry, to be engaged with the arrowhead. So the first criteria of the arrowhead to engage the undercut, mesobuccal and distobuccal, these arrowheads should not contact or touch the neighboring teeth. And it should be within the mesodistal width of the clinical crown. Also, the arrowhead should be parallel to each other. As you can see in the bottom photograph, these two arrowheads should be parallel to each other and not diverging nor converging. And if you look from above, these arrowheads should make 45 degrees with the bridge. When you look from above, the arrowhead should be 45 degrees with the bridge. And now what are the features of the bridge? The bridge should be half of the clinical crown, as we can see in the top photograph. It should be in the middle of the clinical crown. It should be 45 degrees to the long axis of the crown. So now you can see the bridge in the bottom photograph. It makes an angle of 45 degrees to the clinical crown. It should be parallel to the occlusal plane, as we can see in the top photograph. We have two dotted lines. One is marking the bridge, and the other one is the occlusal plane. The bridge should be parallel to the occlusal plane. and it should follow the arch. So if you look from above, the bridge should go and follow the arch line. So now that was the criteria of the arrowhead and the bridge. What about the flyover? The flyover should be closely adapted. As you can see in the top photograph, the arrowhead should be closely adapted above the embrasure. It should not be lifted up or having a space of 1 to 2 millimeter below this retentive arm or flyover, because simply the patient will bite on it and it's not going to be comfortable for the patient, and at the same time the wire will break. Now to come to the retentive arm should extend 2/3 of the pallet, and it should take about 1 millimeter of clearance all the way along, and it should be finished with a retentive tag. Now why we leave 1 millimeter? Because we need enough thickness of the acrylic below it, because if it's less than 1 millimeter the acrylic will fracture. So at least we need 1 millimeter below a retentive arm, and the wire should not touch the pallet. Make sure not to touch the pallet at any point. We should have a uniform thickness of 1 millimeter below the wire, and we should have a retentive tag at the end that is 1 millimeter as well. And as you can see in the top photograph, the distal retentive arm, after it's go down, it goes mesially, it does not go straight. Why? The mesial retentive arm goes straight, and the reason for that, because we have the soft palate posteriorly, and we don't want to cause a gag reflex, because when I move the retentive arm mesially, I can finish the acrylic more mesially, and by that I would be away from the soft palate. So these are now the criteria of the retentive arm and flyover, and we discussed before the arrowhead and the bridge. For today's session, now you are asked to watch the demonstration done by Ustaz Mahmoud, and then you can start doing your Adams clasp. Thank you.